In 1961, President Kennedy called on all Americans to rise to the challenges of the day. He knew that success depended upon the unity of efforts throughout the federal government and the nation. The Greater Boston Federal Executive Board, one of 28 across the country, fosters communication, coordination, and collaboration with federal, state, and local government agencies. This is your federal government, and I am your host, Diane LeBlanc. Hello, everyone. Today we are featuring the Department of Health and Human Services and one of its component units, the Substance Abuse and Mental Health Services Administration. Our guests today are Christie Hager, who is the Regional Director of the Department of Health and Human Services, and Kathryn Power, who is the Regional Administrator of the Substance Abuse and Mental Health Services Administration. Ladies, welcome. Thank you both for being here.
Thank you.
Christie, I'm going to start with you. You are the Regional Director for the Department of Health and Human Services. What is the mission of the department, commonly referred to as HHS?
The mission and really the focus of the work that we do at the U.S. Department of Health and Human Services is to serve as the federal government's lead agency in protecting the health of all Americans and providing and overseeing, in partnership with states, the provision of some valuable social services for folks as well.
So that's a very sort of broad mission statement. What are some of the programs that HHS is responsible for running and overseeing?
So some examples of the programs relate to, in the social services area, working with states on Head Start programs, on the LIHEAP, or Low Income Heating and Energy Assistance Program for folks and communities, child welfare work. Also in food safety. So the Food and Drug Administration, for example, is a component of the U.S. Department of Health and Human Services. Research, medical research and scientific research, the National Institutes of Health and the Centers for Disease Control, CDC, are also parts of HHS. And then another area, a fourth area of a great work that we do is in health insurance. So through our division of Centers for Medicare and Medicaid Services, we administer more than 1 billion health medical claims a year for the Medicare and Medicaid programs. And the Affordable Care Act now, which is a new program that was created in 2010, has broadened the work, particularly of health insurance, but you'll hear from Kathryn throughout the department's work, new benefits for all Americans.
So that's an awful lot of important stuff that's under the umbrella of HHS, the Department of Health and Human Services. How is the agency structured in order to carry out its missions, both nationally and then sort of regionally?
So as Regional Director, I am part of the Office of the Secretary. We have in the department, throughout the department, operating and staff divisions that are organized not just at headquarters in Washington and in the Washington, D.C. area, but throughout 10 regional offices in the country. So we are in Region 1 of the U.S. Department of Health and Human Services, which is the 6 New England states. And our regional office headquarters are in Boston. And there are about 13 or so of the divisions of the department that have a staff presence in those regional headquarters in Boston that serve all 6 New England states. That includes the Administration for Community Living, which works with seniors on a lot of programs, Medicare and Medicaid, through which we do a lot of work for seniors and for low income through Medicaid. HRSA, which is the Health Resources and Services Administration that oversees community health centers. So that will be familiar to a lot of people in terms of their local neighborhood community health centers. We have one, of course, here in Waltham, the Joseph Smith Community Health Center. all of which are examples of where, and you will hear a lot about the Substance Abuse and Mental Health Services Administration of HHS, another of our divisions, all of which work together on providing really essential services in the communities and in working with state governments and municipal governments in making sure that we're fulfilling, making sure the resources are effectively provided in communities.
So you've touched on an area that we like to cover whenever we tape a show with a federal agency, sort of the partnerships that you have that allow you to do the work. Many federal agencies, they oversee programs. They provide the funding for programs, and they make that funding available to the states, who in turn make it available to the communities. So, I mean, you touched on sort of community health centers and working with states. You might want to talk about this a little bit later, but I just want to make sure we sort of cover that relationship with your partners. And I see Kathryn shaking her head, so she'll probably want to talk about it. But before I move on to Kathryn, Christie, just a little bit about your background and sort of your qualifications to head HHS in this region?
Well, immediately before coming to the Department of Health and Human Services, and I was appointed to my position in March of 2010. I started serving in April of 2010. I served as Chief Health Counsel in the Office of the Speaker when we were developing and drafting health reform legislation that expanded coverage to access here in Massachusetts that was passed in 2006. I have a law degree and a master's degree in public health and have always worked on either as part of state legislative staff or working with state legislators on really developing broad policies that improve our ability to provide health and health coverage and protect the health of people across the state.
Thank you for that, and we're going to come back to that 2006 legislation in a little bit. But now, Kathryn, you are the regional administrator, again, of SAMHSA. Am I saying that correctly?
You are saying it correctly.
Tell us again what that stands for.
The Substance Abuse and Mental Health Services Administration.
Okay. So what does it mean to be the regional administrator of SAMHSA here in the New England region?
Well, first of all, the mission of SAMHSA is one that is to reduce the impact of mental illnesses and substance abuse disorders on America's communities. That's our broad mission. SAMHSA was created a little over 20 years ago as an agency that was specifically going to focus on those conditions that were not necessarily being addressed in other healthcare environments or in other public health environments. And traditionally, both mental illnesses and substance abuse services and disorders were treated by state systems. And so the federal government decided that 20 years ago we needed to have an agency that was focused on looking at these conditions and, in fact, making sure that we pay attention to them. So being regional administrator at SAMHSA in Region 1, this is the first time that SAMHSA has ever had a regional presence. So I've only been in the regional office for almost 3 years now. We're starting our third year. So the 10 of us that are now deployed across the HHS 10 regions that Christie talked about are all new. We've never been in the regions before. We've only been SAMHSA staff at headquarters in Rockville, Maryland. So it gives us an opportunity to step out and to talk with our HHS counterparts, to get them to care as deeply about behavioral health issues as we do, and to work in partnership to make sure that we're talking about both physical health care and mental and behavioral health care in equal proportion.
So, again, a very, very impressive mission statement, but with only one person
Correct.
Here representing such a huge task in the region. How do you actually do your work? Is it by partnering
Yes.
with states and other nonprofits? Talk
Well,
about
and
that.
I think the direction that our administrator, Pam Hyde, gave us when she launched this with the Secretary's permission was to say you need to be out and about and, first of all, talking about the importance of these conditions as, in fact, healthcare is reforming. And one of the most essential features, Diane, of the Affordable Care Act is that it speaks to essential health services and essential health benefits. And for the first time in the history of America, we have included mental and substance use disorders as part of the essential health benefits. So under the law, that now says to Americans, these are not to be considered separate, isolated, unusual conditions. They are health conditions like any other health condition. So that message is the one that Christie and I get to do together a lot, because everyone thinks traditionally about healthcare as the physical side of healthcare, and they don't necessarily immediately think about the prevalence and incidence of behavioral health conditions. And most people really don't know or even think about the commonality of these conditions. We all have a 50% prevalence rate of having a mental illness sometime in our life. 50% prevalence. That's very significant. And I think people don't understand how common these conditions are, because people have been fearful, they have been isolated, they have been harassed, they have been treated differently when they might talk about having a mental illness. So my job is to get out and partner with leadership like Christie, with leadership in HRSA, leadership at the Center for Medicaid and Medicare Services, and connect with state leaders to make sure that those state leaders across the New England states are getting the kinds of resources that SAMHSA can provide.
Those numbers really are staggering. And if one is fortunate enough to not be part of that 50%, I think everybody knows somebody or a close friend or a family member that is in that. I was struck when I looked at the SAMHSA website in preparation for today that sort of right up at the front, the messaging is behavioral health is essential to health. And that is, yes.
It is a key message. It is one of the primary goals and objectives that we have at SAMHSA, is to educate everyone to believe that. I don't think all of America believes that yet. And what we mean by behavioral health is we mean those conditions that are considered either mental or related to substance abuse or related to emotional or psychological health. And so behavioral health is a very broad term. The problem is that many people still are caught up in the Cartesian idea that the mind and the body are separate, and or don't think about their health care in terms of the mind and body inseparability. We want to promote the mind and body inseparability and talk about the fact that if you have a stomach ache, it may in fact be driven by an emotional condition. If you're psychologically having difficulty, it may in fact give you a backache. All of those kinds of things are connected. And when people have a broken arm or they have diabetes, they know what to do about it. When they're feeling like they're mentally distraught or stressed, they may not know what to do about it. And so we're encouraging people to look at their whole self, a whole wellness approach that includes both mind and body.
So you clearly are the spokesperson, and you're out there and you're raising awareness. But again, how does it filter down? I was reading on your website that you provide technical assistance and training opportunities. You know, where would somebody go to learn about those?
Well, I think that SAMHSA, as you know, is funded by Congress, giving particular appropriations for particular programs. We are what is known as a demonstration grant operating division. So Congress says, SAMHSA, we'd like you to take this appropriation and tell us what is a best practice. So let me give you just one example. We have probably over 50 different programs. One example is that Congress said, we want you to show us, SAMHSA, what is a better way to provide primary care and behavioral health care together in the same agency. Lots of people think that this is a good idea. It's called the integration approach, and the Affordable Care Act talks a lot about integration. But how do you deliver a service that is both a primary care health service and a behavioral health service in an agency? So we're testing that through a demonstration grant. We have a technical assistance center. We have lots of materials. We have evidence-based practices. All of those things you can get through our website. So if you're interested in that particular topic, go right to the website, look up integration of primary care and behavioral health care, and you can find those webinars, materials, national technical assistance centers, and that's just one example.
And a lot of folks in local communities, I think, are the beneficiary of a lot of your programs and a lot of what SAMHSA does, and they don't even realize it. I mean, again, in looking out at your website, I see you administer the drug-free communities grants.
We do.
And that money, again, comes from the taxpayer, the federal government,
Yes.
but filters down
Right.
and gets to local communities.
Well, and most of our money is in the federal dollars that come through SAMHSA generally go directly either to local providers or they go through the state mental health and substance abuse authority. And then that authority in turn gives it to local providers. But it is federal money either that come through block grants to provide for services, or it's special programmatic money like the demonstration program. So we have money that flows to schools in terms of improving anti-bullying programs in schools. We have funds that go to the disaster management response teams in each state because we do disaster response. We have suicide prevention dollars that go to local universities and college campuses, many of them in Massachusetts, who get suicide prevention dollars. So those federal funds flow, as Congress has indicated, down to the local communities.
Mm-hmm. So, and I also reading that you do a lot with military families?
We do, and we have an interesting profile with military families, and people often say, what's a small agency like SAMHSA doing, with this population? There's the Department of Defense and the Department of Veterans Affairs, and why is SAMHSA involved in this? And we really started in 2006 hearing from those local providers, local community mental health agencies, local substance abuse agencies who came to us and said, we're really not sure, but we're seeing veterans. We're not quite sure what to do. They're coming into our community agencies. So we understood we had to get community agencies to understand, what do you do? Do you ask someone if they've ever served in the military? Have they ever worn the uniform? Have they ever been in a combat zone? There are many people, by the way, who are not eligible for VA services, particularly people who have been dishonorably discharged, or they may have been during a period when the VA services were not available, given the certain conflict and given the eras. We want to make sure people do appropriate referral to the VA in terms of you have to know where to send people so they can be determined eligible for VA services. We have really taken on a very visible profile about ensuring that the community agencies in the states, and particularly Massachusetts, has a wonderful, wonderful network of response to military service members, veterans, and their families. So we want to encourage that people know that these individuals are in their community. Many of our veterans are unemployed and are homeless. Those are the kinds of providers we want to be sure are knowledgeable about how to make sure they're connected to VA. We think this is a population that really has long and certainly deservedly needs to have behavioral health services when they need them.
Oh. Now, you've both mentioned the Affordable Care Act. So, Christie, I'm going to turn to you to sort of maybe provide a definition to start with.
So the Affordable Care Act is the name that was given to a federal law that was passed on March 23rd of 2010. It provides for new opportunities for access to health insurance coverage for the tens of millions of Americans who lacked it by 2010. It also makes some very historic changes and strengthens benefits in the Medicare program for seniors over the age of 65, as well as certain disabled persons. And it also puts in place some really value-based purchasing practices by the federal government in its purchase of services for Medicare as well as Medicaid to really maximize the investment of federal dollars in providing health care and health services. It makes an unprecedented investment in public health and prevention to work directly with communities to keep them healthy and to work with municipal officials and leaders on what works best for their communities. And it has really been a focus of the work that we have been doing at the department over the past 4 years.
So here in Massachusetts, I mean, you mentioned as part of your background, you actually played a role in the legislation that was passed here in Massachusetts in 2006. And that's sort of, I think, referred to by many as we got mass health in 2006. So if that law required that everybody in Massachusetts get health care through some form, what does that mean in the context of the new Affordable Health Care Act?
So the Affordable Care Act, which, again, federal law passed by Congress in 2006, in 2010 rather, really builds on what we already had here in Massachusetts, and frankly in the majority of New England states that had to that point, passed as strong as they could reforms on the state level without the resources and new tools that the Affordable Care Act now gives them in partnership with the federal government. So we had, by 2010 here in Massachusetts, and as I said, many New England states, already a very long tradition of consumer-oriented insurance regulation, including the fact that in Massachusetts it had been for more than 20 years, you couldn't be prohibited from buying an insurance plan or policy just because you had a pre-existing condition. And this is an example of where now, in the new required benefits that health insurance policies have to include, the creation of a new health insurance marketplace through which to access these new opportunities for coverage. Now the Affordable Care Act not just builds on what we had here as a history in Massachusetts and many other New England states, but now it's always important to remind those of us in Massachusetts who have been used to this, really protection and a very some of the highest quality health insurers in the country already being here in Massachusetts and New England. Remind us that these are now benefits for all states and all Americans in all states. That is it's a historic law. It's really, I think Kathryn mentioned the fact that this is a transformation of the healthcare delivery system. And it's not just here in Massachusetts where we've had this history of very high quality healthcare and very available healthcare services, but now in all states in the country. It's big history.
So in terms of your role at HHS in the region, what's your role in overseeing implementation or carrying out implementation?
So I have been, as the senior representative of Secretary Kathleen Sebelius to the 6 New England states, I serve as her liaison to the 6 New England governors, to the state health and human service secretariats in each state, federally recognized Indian tribes as well in New England. We have about 10 of them here in New England in the 6 states combined. But also with municipal level leaders. And I mention that because part of the Affordable Care Act is a real strengthening of the relationship between this federal department and communities and directly with cities and towns. So it's been a very important part of the work that we've done. So over the past 4 years, our work really has focused on very broad education about what the Affordable Care Act is and how much benefit it has for all of us, not just for seniors and not just for low income and middle income, but for really all of us. And you mentioned earlier, you referred to the fact that there are benefits that people may be receiving related to behavioral health and primary care that they may not realize are because of SAMHSA's work or work that we do at HHS. And similarly with the Affordable Care Act, I mean, this was passed in 2010 and a lot has happened since then. I mean, we have seen seniors saving more than $600 or $700 on average if they hit that donut hole, that gap in prescription coverage, for example, in the Medicare program. We've seen people in Massachusetts and throughout the country, state by state, accessing preventive health services for the first time with no out-of-pocket costs. So screening mammography, screening colonoscopy, annual vaccinations, for example. We have seen here in Massachusetts, the state law that was passed in 2006 provided for young adults to be kept on their family's coverage until they turn 26. That state law required that young adult to be defined as an IRS dependent. Well, here's another example how the Affordable Care Act has made changes even for us in Massachusetts who had some of the best access to coverage before the Affordable Care Act. Now, 26-year-old, up to 26-year-old young adult dependent or a child can be included on the family's coverage. They don't have to be a dependent. They don't have to live with you or even in the same state. Wow. This has meant coverage since 2010, 2011 already for millions of young adults throughout the country.
Yeah, that is a good point, because many sort of have the impression that even though the Affordable Care Act has certainly been talked about over the past few years, that it didn't really come to be until 2014.
Yeah.
So in our show here, in the Your Federal Government show, we stay away from the political. We try to focus on factual information to tell our viewers about the different federal agencies, what their mission is, and to provide them with information that hopefully they find valuable. But in terms of the Affordable Care Act, you know, we need to cover a couple things. Certainly, in terms of the rollout, there were some issues with the website, which is, you know, the portal, and maybe talk about where we're at with the website.
So we've mentioned that one of the real cornerstone provisions with the Affordable Care Act is creating what are these new health insurance marketplaces, a new health insurance marketplace in each state for people to go through to apply for a private health insurance plan with the use of tax credits, federal tax credits, if they make up to $44,000 for an individual or $94,000 for a family of 4, for example. Or to apply for the state's Medicaid program. So what we've seen also across the country is it was a state-by-state decision on what that marketplace would look like. So in 4 of the 6 New England states, they created a state-based marketplace. So here in Massachusetts, it's called the Massachusetts Health Connector. In the states that chose not to create their own state-based marketplace, it's operated by the Department of Health and Human Services, either solely by the department or in partnership with the state. So in New Hampshire, we partner with the state of New Hampshire on their marketplace. Maine is fully facilitated by the Department of Health and Human Services. So the important thing to note that no matter whether you're in a state-based marketplace or federally facilitated, there are many ways to apply for coverage and to find out what your options are. There's a website, there's a toll-free call center, and there are people in person who are available to assist you in your communities. So an investment that the department has made, either directly with communities or through states and state-based marketplaces, is to invest in people who would be available in your neighborhood locally to explain to you, guide you through how to see what your options are, how to side-by-side compare what your options might be. And it's important just to remember, I think, that there's a website, there's an 800 call center, toll-free call center, and then there are also in-person assisters. That includes people who are already working in community health centers, more than 30 in Massachusetts, for example, all received additional funding to do this kind of work. So there's a number of different ways, and you know, earlier with the technical issues that existed for the federal marketplace website, healthcare.gov, we have seen, you know, it's working pretty well if more than 2 million people in just the first 3 months of a 6-month open enrollment period have already enrolled.
So
actually.
when I went to the website,
Yeah.
you know, sort of the homepage comes up, and it's, you know, the Affordable Care Act, 4 ways to enroll.
Yeah.
You can phone, you can go online, you can talk to us in person, or you can mail in an application. So I decided to call. And when I called, as you said, it just kicked me right over to the Massachusetts Health Connector.
That's right.
And sort of then they're providing all of the information.
Yeah.
But I was curious about the in-person folks, because this is a big decision, and it is complex, and you want to make the right decision for yourself and for your family. And again, online will work for some people, over the phone will work for some people, but that option of being able to go in and sit and speak with somebody face to face, can you tell our viewers a little bit more about how do they find these people in their local community? If they were to call their local city hall, would somebody at City Hall know where they were? Who knows where these people are in local communities?
Well, one way to find them is is not just through the website. So as you said, you called the call center and they transferred you or gave you information about the Massachusetts Health Connector. The website similarly, anyone who goes on healthcare.gov can enter the state. The first thing they ask you is what state you live in, and then they'll send you to the local resources. There's also resources on numerous websites, and we'll make sure that we provide them for your viewers, on where to find local help. So by entering your zip code, for example, depending on where you live, you can get a list of places where people are trained and certified on being able to guide you to where your options are and for you to make your own decision about what coverage is right for you. Now, throughout the country and certainly here in New England, most people who have insurance have it through their employers. We know one of the goals of the Affordable Care Act is to reach those people who don't have access and some of them never had access to health insurance. So I meet constantly wherever I go people who say to me, this is the first time that I am ever going to have health insurance. That is a life-changing, life-saving, really change in people's lives. And so that's really where, you mentioned a lot of people thought the Affordable Care Act just became effective January 1, 2014. This open enrollment, the first open enrollment period for these new health insurance marketplaces started October 1st. It'll end at the end of March. So it's a 6-month long, pretty long open enrollment. And we are very much focused on making sure people are directed to those resources.
But now in Massachusetts, where we had our 2006 legislation that, again, required everybody to have health care, how many Massachusetts citizens did we still have who weren't covered, by some sort of health care? Any sense of that?
So, Massachusetts, again, started with the implementation of the federal health care law as being the most insured state in the country.
There we go.
So we were down to 4% or less of our total population of 6.5 million was without health insurance, and even fewer percentage of children without health insurance. We have had historic highs in coverage of children at all income levels. So we were talking not as many people percentage-wise of the population in Massachusetts. But nonetheless, these were new opportunities for people to get either coverage for the first time or better coverage than what they had. And we're seeing that experience to be very tremendous in most states where people may have been insured, but they're getting much better health insurance now.
And in particular, Diane, we're very concerned, even though New England as a whole has a smaller number of uninsured people than the rest of the regions, but we're still concerned in particular around those individuals who may have gotten some level of care, but were totally underinsured relative to their overall health care aspects. So for example, many people with mental illnesses and substance use conditions and addictions are poor. They don't have insurance, and they get federally funded or state-funded care. We're very concerned about that group of individuals who may go to a methadone clinic or who may be in a recovery support services, but clearly they are not. Many people with these illnesses are not employed, and so therefore they don't have any access to insurance. So that's why SAMHSA in particular, in working with HHS's enrollment and engagement efforts, really want to get that population engaged, because oftentimes their health care has suffered. You may have had medications and they were medications who were helping you manage your schizophrenia, but you have never had a blood test or a blood pressure test. And oftentimes that's what's happened when those systems were separated, is that there would be mental health or substance abuse care, but no physical health care. And so the beauty of what we can now do under the Affordable Care Act is to make sure that those individuals can get appropriate and proper insurance coverage for their total health care, not just for the conditions that they may have been receiving from state subsidized services.
So that really is, those are some significant changes and benefits for the populations that SAMHSA is serving. Christie, one of the other things, we heard after the initiation of the rollout was that many folks were surprised that they weren't able to stay on their existing plan. Talk a little bit about that.
So that actually affected a relatively small number of people from state to state and nationally. So we've mentioned already that the Affordable Care Act requires a certain minimum level of coverage. So your insurance must be real insurance. It must cover you for when you're most ill. It must have reasonable cost sharing requirements. So that's, you know, deductibles and co-pays and how much you pay for each visit, et cetera. So some insurers, before the 2014 year began, had issued letters to folks saying that, and again, this was something they did before the Affordable Care Act was passed in 2010 and before 2014. You know, every year those policies were subject to cancellation. So some people received letters that told them that their policies were canceled. The Affordable Care Act required, if an insurer did that, they had to provide them with the information for where to go to get continued coverage. It created some confusion for some people, but we made sure that it was very clear that in a state where a cancellation would become effective, that people had the information of where to go now through the new health insurance marketplace, new products, new benefits available to them. And in some states, the insurers didn't do that at all. So in fact, people were just able to transition right to the new coverage and no confusion
So
there.
it really did vary from state to state, and we didn't hear
Very
a lot
little.
about that
No.
in Massachusetts.
No, and again, you know, it has to do with the market, the insurance market that we had here prior to this year. We did not have a market where there were really many policies that were going to need to be completely changed because they weren't going to meet the requirements for really affordable and quality coverage that the Affordable Care Act requires.
Earlier, you mentioned very briefly tax credits. Can you talk a little bit more about tax credits available?
Yes, so this is again another example where there's the Affordable Care Act builds on very protective health laws that we had prior to this. That, for example, through the Health Connector, you could purchase, depending on your income, up to, say, $30,000, $32,000 or so for an individual, could receive a subsidy from the connector to purchase coverage. Now the Affordable Care Act raises to 400% of what we call the federal poverty level, but in real dollar terms, it's about $44,000 for an individual, $94,200 or so for a family of 4. Can get what's called an advanced premium tax credit. And this is, again, for people who don't already have coverage through their employer or who don't have affordable coverage through their employer. They can receive this advanced premium tax credit. So when you enroll for coverage at the beginning of the policy year, you would, based on your previous W-2, estimate what your income's going to be for the following year, and then decide whether it's monthly or an annualized basis how to apply that premium tax credit. It is a tremendous savings for people, and it's part of meeting that one of the goals, major goals of the Affordable Care Act, is to actually provide affordable coverage for folks. It's also true that the Affordable Care Act seeks to really level the playing field for businesses who do contribute to the health insurance premiums and offer coverage for their workers. So also through the state-based marketplace and, for example, the Health Connector, small businesses can now purchase coverage for their workers and receive a tax credit themselves, the small businesses. So up to 50%, if they're eligible. You have to have, you know, fewer than 25 full-time equivalent employees. You have to have average wages of $50,000 or less, for example, but they can receive a tax credit of up to 50% of what they contribute to their employees health coverage. You know, small businesses have to compete with large businesses, and with some businesses who before now haven't been offering or contributing to health insurance for their workers. So this is a benefit for them, and it's available to nonprofits as well, up to 35%, which is less well understood because it's called a tax credit, but it's actually available to nonprofits as well, who also qualify based on some of those similar factors, of up to 35% of their contribution to their health insurance, workers' health insurance premiums. Now that the marketplaces are created, they have to purchase it through, for example, in Massachusetts, through the connector. But some of the most compelling stories I've heard from people I've met who have benefited, small business owners who have benefited from this tax credit, have been small nonprofits, daycare centers. So it's really a benefit worth knowing about. And we partner closely with our colleagues in the U.S. Small Business Administration with outreach to small businesses about this benefit for them.
So small businesses and nonprofits, they access these benefits through the very same website that an individual would go to access the benefits. They come up and they see the marketplace screen and they go from there.
And they go to the small business section.
Now, we talked a little bit about some of the benefits that seniors have seen going back to 2010 as a result of this act. So seniors and they're on Medicare. What are the changes there? If somebody is currently on Medicare, do they need to do anything?
So this has been a wonderful area of the work that we've done through the Affordable Care Act, and you know, Medicare is purely federal law, and it's a federal program, purely federal program. So, as aggressive and protective as state health reforms laws have been prior to the Affordable Care Act, there wasn't anything they could do about Medicare. So the Affordable Care Act, some of its most significant provisions strengthen the Medicare program. And those have been some of the earliest provisions that became effective of the Affordable Care Act. So back in 2010, you know, seniors, in 2010, started saving money when they hit the donut hole on their prescription drugs. If they hit the donut hole in 2010, they received a $250 rebate check. And then afterwards, those years, it was based on how much their spending was. It really protected them from when they needed prescription drugs the most. It also, effective January of 2011, so Medicare beneficiaries were the first ones to benefit from free preventive services, preventive health services. So you want to go and have a wellness discussion with how to change your lifestyle to have more healthy practices. You want to have a screening colonoscopy, screening mammography, no copays, no co-insurance, no deductibles, no excuses, I always say to seniors. We wanted them to make sure that they knew those benefits were available to them and that they used them. Those free preventive services now are available through the health insurance marketplaces and outside the marketplaces to all, not just Medicare beneficiaries. So there's that. There's also a tremendous investment through a partnership between the Department of Health and Human Services and the U.S. Department of Justice in reducing Medicare fraud. So the billions of dollars a year that can be saved from otherwise paying false claims that are made to the Medicare program, which I always say to seniors and to the disabled on Medicare, we would much rather spend on you than on paying false claims and fraudulent claims. That has represented some tremendous recoveries. It's an area of work that we do at the community level through many partners with seniors and other folks on Medicare to educate them about the very clever fraudulent schemes that are perpetrated against Medicare beneficiaries all the time. And to make sure that if they see something or if they see something on their summary notice of benefits that doesn't look right, that they go to their local senior center. Has tremendous resources available to them in person to look at, but that there are partners, and if they, you know, somebody comes to their door or calls them and says, if you're on Medicare, we have some free things for you, it's never free. And if they feel like they've given information out, personal information they shouldn't have, don't feel ashamed, don't feel stupid. call 1-800-Medicare, call 1-800-HHS-TIPS. We hear from our colleagues in the HHS Office of Inspector General all the time that some of their largest recoveries of fraudulent activity and fraudulent claims paid in the Medicare program have been on the basis of a single beneficiary tip to one of those places.
So, but do our seniors who are on Medicare, do they need to do anything? Do they need to know about the connector? No changes?
No, that's not for them.
Okay.
They were already taken care of and benefiting since 2010, and the connector's not, they don't need it.
They're good.
Yeah.
So Kathryn, I mean, again, you talked about the impact that this has, that the Affordable Care Act has on your work. How can our viewers who might, have the need for the services that you provide, how do they learn about the additional services that are available to them now?
Well, the Affordable Care Act really outlines those 10 essential services, and the fact that everyone publicly now knows that mental health and substance abuse services are part of those services is really a public education process. And I think that as individuals then have the opportunity to choose their insurance, it's important for them to look at what they think their needs are and what kind of coverage they think they want to have for those behavioral health conditions. So we just ask people to ask that question of themselves.
Sure.
What do you think? What is your current health condition, and or how do you project the kind of coverage that you want, knowing that not only does the Affordable Care Act encourage the kind of prevention approaches that Christie talked about, but it absolutely focuses on looking at integrated care. So you want insurance coverage that's going to have that connectivity between your primary care and your behavioral health care. So something to look forward to. It shouldn't be isolated. It shouldn't be separated anymore. And I think the other piece that comes along with that is that I always think of this as historic, in the sense that the Patient Protection and Affordable Care Act really couples and enhances what was initially the Mental Health Parity and Addiction Equity Act. And so you have these two major pieces that are reinforcing each other, that finally, once and for all, says you cannot discriminate against offering services under parity in any way, shape, or form that makes it look different than the other kinds of services or benefits that you would offer under physical health care. And for too long, Diane, that's been the case. People were discriminated against in terms of the amount of coverage. Actually, Medicare even used to charge a higher copay for psychiatric services. Now that's changing with the law. Wow. So even the fact that we now have this equity and parity law coupled with the Affordable Care Act extensions, it really gives the platform on which people with these conditions can really feel that they can finally access appropriately and on equal par the kinds of behavioral health conditions and the kinds of healthcare solutions that they really should have. So we see that as our main message, is that we want to be sure that, again, individuals who have these conditions are educated and knowledgeable about what the options are, that they're aware about where do they file a complaint if they think that they've been discriminated against in terms of parity. And there's lots of good information about that from our website in terms of who's responsible. So CMS and Department of Treasury and Department of Labor are involved in making sure that parity conditions are met. And that, to me, is going to be what will be tested in 2014 and in 2015 and beyond. Because now these insurance plans have to meet parity. And I think that that's a hugely important issue relative to people with these conditions.
This act is huge. And nothing is ever perfect, sort of right out of the gate. But you go along and you learn and you make changes as you need to. We're actually going to be devoting an entire show to the Affordable Care Act, and thanks to Christie, we're going to have some folks in from the Health Connector, and we'll be able to sort of drill down into some of these areas for our viewers, because it is complex and it is important. So we have covered an awful lot of territory. What haven't we told viewers that they need to know about HHS, about SAMHSA?
Well, I think that I would encourage all of the viewers to become more knowledgeable about what SAMHSA provides. We have a whole range of services. I'd encourage people, as you did, Diane, to go into the website. There's lots of different priorities There's lots of different priority areas. We have a focus on prevention of mental illnesses and prevention of substance abuse disorders. We have evidence-based practices on learning how to deliver trauma-informed care, which we think is a very important part of behavioral health conditions. We consider trauma to almost be a universal factor for many people with mental illnesses and substance use disorder conditions. And so a lot of that specific information is not only good information to have yourself and for your family members, but also I think will help educate them about what questions they should be asking about the kind of insurance they want.
Great. Christie?
I will just say also that there is a tremendous amount of resources for people, very understandable information, whether it's based on any types of health conditions they might have, or any racial or ethnic groups, on hhs.gov/healthcare, and I know we're going to provide this website address. Really accessible information for people to just know the presence of the U.S. Department of Health and Human Services. I think that because we have tremendous community based assets in this part of the country, and anywhere in the country where that's the case, it's often hard to see the presence of the federal department and the very strong partnerships. And I'll tell you, with leadership at the department, Secretary Sebelius is a former governor. We are constantly working very closely with our partners in the states and in communities. So just to make sure that people know that their best interests and the protection of their health is really something we're working on every day.
Well, earlier you mentioned the Joseph Smith Community Health Center, and my community is Waltham, Massachusetts, and that health center has a presence in Waltham, Massachusetts. Now, I know how many citizens from my community avail themselves to the wonderful services that they provide. I don't know what we would do if we didn't have them in our community, but I will tell you, most people don't look at that entity and say, oh, there are the federal dollars. That's the federal government. Not that they need to, but you know, they just really, really are a tremendous resource. And you know, so you talk about the website, and you know, I work for a federal agency, and websites and communicating in that way necessary, allows us to reach so many more people so much more quickly. But again, not for everybody. And sometimes when something's really important, and there is a price tag associated with it, but we do a mailing, and we you know, send information on, you know, Medicare and you in 2014, this is what this means. Is there going to be any sort of a mass mailing, so to speak, around the Affordable Care Act?
Well, it's actually interesting that you mention that, because that's one of the opportunities that I think that, you know, we work on with our local partners. You know, for example, we have worked with mayors across the country. You know, city and town halls send a lot of mail about a lot of things to their residents. This is something to sort of add to the materials and resources they want their residents to know about. We really look to try to leverage what reresources and what materials are already being shared with people in the communities to try to partner with those, and it's led to some interesting practices across the country. But that, combined with you know, digital advertising, online, et cetera, it's a lot of how we're getting to reach folks. But
good information. So I want to thank, we really did cover an awful lot, but we are at the end of the time. I look forward to doing the next show as well on the Affordable Care Act. So I want to thank Regional Director Hager and Regional Administrator Power for being with us today and for helping us to better understand the work of the Department of Health and Human Services, and in particular the work of the Substance Abuse and Mental Health Services Administration. I thank you for watching, and I hope that you will continue to join us as we feature other federal agencies on your federal government.